know where is the collapsed ductus venosus, probably closer here to the umbilical segment of the portal vein. So it would have come out, and on higher sections it will enter the inferior vena cava. Notice that that fissure is a broad plane. It's a line on transverse, it's a line on sagittal, so it is not a linear kind of fissure, but it's rather fairly broad. And that is our divider for caudate lobe from left lobe of the liver. This vein does not recanalize in adults. You don't see this vein ever again, except perhaps in the very small neonate that has umbilical vein catheters. You might see it, but once the child grows, this vein is obliterated and does not recanalize in portal hypertension. I mentioned the caudate lobe. When you think of caudate, you think of something caudal, but yet that's not really what this means. Caudate in Latin means tail. So the caudate lobe is like the stubby tail of a dog. Here's a little puppy here. And it's actually one of the more cranial parts of the liver. Now we pay attention to the caudate lobe because the caudate lobe is functionally an autonomous segment. And it has often been said that it is spared in liver disease. It has its own blood supply. It takes blood supply from the right and the left portal veins. And you can prove this to yourself if you carefully scan. If you have a good patient, a thin patient, and you look around the portal veins, you can see small branches entering the caudate lobe. And you can also see venous drainage, separate venous drainage directly into the inferior vena cava. And supposedly that drainage here is what helps to protect the caudate from other diseases. Now, another thing you should know about the caudate is that it itself can look like a mass sometimes. We call that a pseudomass. Here's a section of the liver, and it looks like there's a mass in the caudate. So I would caution you, this is an artifact. If you ever think you see a mass in the caudate, ask yourself first, are you sure that that's not a pseudomass? What happens with the pseudomass, the ultrasound beam comes through the portal structures and becomes attenuated. So it partially drops out, giving it the appearance of a hypoechoic mass. If you move off of this porta and come in with the beam from different angles, you will see that this is not truly a mass. That's why it's a pseudomass. Also, the caudate lobe can become enlarged, especially with cirrhosis. We can actually measure that. This is described in the literature. And the caudate is enlarged when a certain ratio of the caudate to the right lobe is enlarged. So what we would do, we would take a transverse section of the liver, we would take the medial margin of the caudate and the lateral margin as the lateral margin of the portal vein. That we would measure as the width of the caudate lobe, and the rest of it is the width of the right lobe. Then we would take a ratio of C over R, or caudate over right lobe, and if the ratio is over 0.65, that becomes an enlarged caudate. If the ratio is over 0.73 or so, that's very specific for cirrhosis of the liver. But you have to have the whole transverse scan on one picture. It's easier to do on CT. So now that we've talked about the hepatic and the portal veins, this leads us into the basis of modern lobar and segmental anatomy. This is the basis of surgical procedures nowadays. This is the reason why surgeons can go in and remove a subsegment of the liver, let's say a metastasis in a subsegment, and not harm other parts of the liver. This is possible because of now our understanding of this lobar and segmental anatomy. Now, we've already told you that hepatic veins drain peripherally, so they are interlobar and intersegmental, therefore we use them as dividers. portal veins feed the segments centrally, so they are intralobar, intrasegmental, and we use them to name the segments. So here we'll start with the hepatic veins as dividers. Here's a transverse section high in the liver, and we see the 3 hepatic veins coming together at the inferior vena cava. The middle hepatic vein divides the liver into right lobe and left lobe. The left hepatic vein divides the left lobe into medial and lateral segments. But this only occurs in the high parts, cranial parts of the liver. That's where the hepatic vein is. The right hepatic vein divides the right lobe into anterior and posterior sections. Okay, so now we have right and left lobes divided. Now the portal veins, they feed the segments, we name the segments, and they define the segments. Okay, so here we have a portal vein with bright walls. The main portal vein just came into the liver and immediately divided into a right portal vein, which is rather short because it suddenly splits into the anterior segment and the posterior segment. Okay, so this is the division of the right portal vein. So here is the right anterior segment, and here is the right posterior segment of the liver. And notice, here's our right hepatic vein, and here's our middle hepatic vein. This plane of separation, middle hepatic vein in line with the inferior vena cava, is our divider of the liver into right lobe and left lobe. And the right lobe is further subdivided into anterior and posterior segments. The left lobe has its own divisions. Now here, after the vein split, the main portal vein, the left portal vein has a longer course. It travels towards the left lobe and suddenly takes an abrupt anterior turn. This is the only part of the portal system that suddenly aims anteriorly. Okay, that's the umbilical segment of the left portal vein. And it sends off lateral branches and medial branches. So this would be the medial segment of the left lobe, and these are lateral segments of the left lobe. This is used as a divider. This is the only part of the portal venous system that is used as a divider. I told you hepatic veins are dividers, but this is the only part of the portal system that's used as a divider in the midsection of the liver. Okay? That's our division of middle hepatic vein dividing right and left lobes. So here we have our subdivisions on subdivisions in this case of the left lobe. I've already mentioned 3. I'd like to put them all together for you. So we have dividers of the left lobe into medial and lateral segments. High up on high sections, it's the left hepatic vein that divides the left lobe into medial and lateral segments. In the middle of the liver, it's the umbilical segment of the left portal vein, which divides the liver into medial and lateral segments. And lower down, where there are no big veins, we have the echogenic falciform ligament coming in and the umbilical fissure dividing the liver into dividing the left lobe into medial and lateral segments. So superior, mid, and inferior parts. Another point that I'd like to bring up here is about the division of the main portal vein. Precisely where the main portal vein comes in and splits, right in that line here, we can use that as another anatomic divider of the liver. If we look at the liver frontally or en face, we'll see that that part of the portal vein divides the liver into superior and inferior segments. However, so that's on coronal sections. If we look transversely, we slice up the liver, and we find that division in the middle of the liver, that will divide further into anterior and posterior segments. So the same vein it's a tubular structure, can divide things into superior and inferior, as well as anterior and posterior. So it becomes useful. All of that put together helps us subdivide the liver into subsegments, which is useful, very useful for the surgeon, because if we can place a lesion in a specific segment, the surgeon can then go after that lesion and remove it without harming other vascular supplied segments of the liver. This is the basis of the Couineau system, a French system that divides the liver into 8 segments. If we look at the liver from the front, this would be the left anterior lateral segment. Behind it would be the left posterior lateral segment. Way in the back is the caudate lobe. That's always segment 1 in any system of classification because it kind of stands alone, so we get it out of the way. Then we see the medial segments. We have a superior and inferior medial subsegment. And when we get to the right lobe, here we have anterior superior in blue, and we have anterior inferior in purple. For you to see the back, I've rotated this liver slightly. So here's anterior superior, anterior inferior. In the back is posterior inferior and posterior superior. These segments are labeled 5, 6, 7, and 8. It's kind of an unusual system. It kind of twists around like a figure 8. Nonetheless, each segment has a number. Now, I don't think that you should learn all of these segments with numbers because you have to know what your surgeon uses. Your surgeon may not use this classification. But if you divide and explain that it's left posterolateral or right posterior superior, they will know then which part of the liver the lesion is in. So here's a little quiz. Name the subsegment with the cyst. Okay, this is a transverse scan of the liver. So where would you place this cyst? What subsegment? This is transverse, and here's a sagittal scan. Okay, well, I hope that you were able to see that this is the middle hepatic vein, so this is in the right lobe. And this is the right hepatic vein, so that's in the anterior segment of the right lobe. And it's up high by the large hepatic veins, so it's in the anterior superior part of the right lobe, which is segment 8. And that is confirmed here on the sagittal where this cyst is high up sagittally rather than in the lower parts of the liver. So then you can tell, you can precisely locate this lesion. Let's look a little bit at the portal veins. For this, we have to talk about the Doppler a little bit because nowadays we do more and more Doppler. In a normal main portal vein, we have continuous forward flow. The liver is always available for detoxification of substances, anything that you eat, anything, any breakdown products from the spleen, the gut, etc. So it's constant forward flow with a low velocity. If you did velocities, usually they're 15 to 28 or 30 centimeters per second. The flow is into the liver, shown here on this color Doppler. Red means flow towards, so we have flow towards the liver. It's an undulating pattern which reflects respiratory variation and may reflect cardiac variation. It's a slightly turbulent, rough, low rumble kind of flow. That's because it's located between two capillary beds, between the mesenteric venous system and the hepatic venous system. What's abnormal? Well, abnormal is when that flow becomes too pulsatile. It may then start resembling hepatic vein pulsatility, and that would mean that there's elevated right heart pressures and that there's transmission of pressure through the sinusoids into the veins. We can see this with tricuspid regurgitation. We can see it with moderate to severe right heart failure or pericarditis. The exception would be in the young child, where the liver is so soft and pliable that it can actually transmit cardiac pulsations and central venous pulsations from the heart. Here is an abnormal pattern of a main portal vein. Suddenly it becomes too flat, very flat and continuous flow with loss of that undulating pattern, and that's what we'd see with cirrhosis and hepatic fibrosis, where the liver becomes stiff and we lose that undulation. The hepatic artery, now let's look at the hepatic artery. The hepatic artery typically has a very rapid systolic acceleration. It's a nice arterial pattern. It has continuous forward flow of blood into the liver throughout the cardiac cycle. So it has a low resistance pattern. In other words, fairly high diastolic flow because blood freely enters the liver. It is always in the same direction as the main portal vein flow. So on color Doppler, these two vessels, the artery and the main portal vein, are always the same color. So if you set your color map with red, meaning towards the transducer, both will be red. If you turned it blue, as meaning towards the transducer, both should be blue. But you should not have one red and one blue, because of course this has nothing to do with oxygenation, it's direction. It's also interesting that the portal vein and the hepatic artery sort of have a mutual understanding between themselves. The portal vein carries 70 to 80% of the blood into the liver, whereas the hepatic artery only brings in 20 to 30% of the blood flow. But the artery brings in the fresh oxygenated flow, but the portal vein brings in deoxygenated flow from the splenomesenteric system. However, it's carrying a lot of flow. And there is a certain homeostatic mechanism between the portal vein and the artery. So if the portal vein flow decreases, there's a signal given to the artery to increase blood flow. So as a liver becomes sicker and develops more cirrhosis and blood flow cannot come in through the portal system, the arteries tend to enlarge to bring in more flow. Okay, so you saw the normal waveform. Now here's an abnormal waveform. The waveform becomes abnormal when the resistance becomes increased and diastolic flow drops. So we see such a pattern after eating, postprandial. We also see this with portal hypertension, more resistance in the liver, and more importantly these days, transplant rejection. We will pay attention to the arterial waveform. Now, another way that the artery has abnormal Doppler is post-liver transplant. That's when it becomes important to us. If we see a tardus parvus waveform after liver transplant, this is an abnormal finding. We would see low upstroke and fairly low velocity, which means that proportionately the diastolic flow is elevated. So we have a prolonged systolic acceleration time and then this tardus parvus waveform. What it means is that there is a hepatic artery stenosis, anastomosis. There's an anastomotic stenosis post-operatively. So we are not seeing the flow through the stenosis itself, but we are seeing the flow downstream from the stenosis when the flow has lost energy and is trying to relaminarize and is weak. And that's why we get the tardus parvus syndrome. So we don't actually see the stenosis, we just see the effect of the stenosis downstream in a transplant. Now let's look